Thank you, and thanks, Ruben, for validating a lot of my own uncertainties when taking care of these patients. Sorry, I got it. I don't have anything to disclose. Just to touch briefly on what I'm going to tell you, relatively briefly, I just wanted to do a quick, very quick review of our options for cytoreduction and where the data come from, and how well they work, and specifically kind of framing it the way Ruben just described in terms of reducing vascular risk and controlling symptoms, and truly being disease modifying. For interferon, we'll sort of touch on its history and with comparative studies that are ongoing. So I'm going to use a case from my own practice, a young woman who has an elevated platelet count, just known just by routine blood work. She's well, her spleen's not palpable, her other counts are essentially normal. She has a platelet count of 1.8 million. A ferritin is normal. Her bone marrow biopsy is shown. It's normocellular, some megakaryocyte clustering, but otherwise pretty unremarkable. And she's found after a JAK2 mutation testing is negative to have one of the type 1 52 base pair deletion mutations in calreticulate. And so the question is whether there's any indication for cytoreduction in this patient, either because of vascular risk or for symptoms. And so just I'm very robotic when I'm thinking about risk assessment. In terms of vascular risk, I tend to use the IPSIT criteria, and I think you can look at this and see that she doesn't have any risk factors. And you'll notice that platelet count actually doesn't fit into these risk criteria. So in terms of vascular risk, is there an indication for cytoreductive therapy? The answer is no. She's low risk. And in terms of symptoms, she has none. So it's going to be hard to get better. But 24 months later, she comes back with frequent debilitating headaches, dysesthesias in her hands, so all of these symptoms of microvascular disarray, and they're unresponsive to aspirin. And now you have a young person at low vascular risk with really debilitating symptoms, and what can you do? Important to note these data, which actually show that the survival in ET is not normal, but it's pretty near normal, particularly in the first 10 years. And when you're talking about a young person, I think the burden is really in not being overly aggressive in these patients. And so I think that's always an important thing to keep in mind. Where do we get cytoreductive therapy in terms of what we use and the data that support it? This was the first placebo-controlled study looking at hydroxyurea and really showed a dramatic reduction in vascular events in patients treated with Hydrea versus placebo. This is where that instinct comes from. These are patients at high risk. So I would say in terms of my little scoring system, it gets a gold star for reducing vascular risk. Controlling symptoms, that study didn't actually look at this, but we have a lot of data from the COMFORT-1 and COMFORT-2 placebo and best available therapy studies, which really shows pretty clearly that there's not a lot of activity in terms of controlling symptoms. And we also know that these aren't disease modifying in any way. So the next sort of pivotal study that we often refer to is called the PT1 study. This was done by the MRC, and it showed that Hydrea was superior to anagrelide in high-risk ET in terms of preventing vascular events. This was a superiority study. And there was a subsequent study that looked at a formulation not available to us in the US using a non-inferiority design, but showed that anagrelide is not inferior to hydroxyurea for treatment of essential thrombocythemia. I sort of conclude that it's actually an effective second-line agent for ET in terms of vascular risk. So this is my little score sheet for Hydrea versus anagrelide. I'm being generous with the question marks about controlling symptoms. I actually think they have very little impact in terms of that. And I think we can pretty definitively say that they're not disease modifying. So that brings us really to interferon. And interferon this was the first letter to the Lancet by Dr. Silver, who sort of seeing the activity of interferon in CML at the time, and noting its anti-PDGF activity, which is interesting because I think we think of PDGF as part of the picture, but not certainly the only cytokine that's relevant to this disease process. They tested, he treated several patients with interferon. This is now Intron A, 3 million units, 3 times a week, and looked at red count, white hemoglobin, white count, spleen size, and noticed amelioration for patients. So the issue with Intron alpha was really the toxicity. It's very difficult to tolerate interferon and has a lot of overlapping toxicity with a lot of what we capture now in Rubin's symptom tool. And so it made for a problem in treating patients when you're trying to control symptoms. And not to mention the injection part. And so there were long-acting interferons. The ones I'm going to focus on are pegylated interferon alpha 2 beta, which was tested in MD Anderson and was convenient in that it allowed now for weekly administration. It appeared to be also quite active, but the toxicity was pretty equivalent to Intron alpha, and so that was a problem. And so pegylated interferon alpha 2A is the drug that's FDA approved for treatment of hepatitis C. It has special chemical features that make it probably quite potent. Same situation where you could have weekly administration. And it really was the first agent that was shown to be disease modifying. So the first agent outside of allogeneic stem cell transplantation, which really seemed to impact the clonal burden of disease. So this is the study that was done by Jean-Jacques Kilagien, looking at pegylated interferon alpha 2A, and showed I'm sorry, it's a little bit faint, but essentially you're looking at, so I can get this to work. Well, partial responses down at the bottom and complete responses on the top, and essentially over 95% of patients achieved a complete remission, and very few people actually dropped out of the treatment arm. So this appeared to both be more tolerant and highly active. And I think most tantalizing was this figure, which actually looked at the allele burden. Remember, this was actually probably the first time we could look at it because of the discovery of the JAK2 V617F mutation. And you can see that over time, the allele burden decreased and sometimes led to complete molecular remissions. Likewise, an MD Anderson study, which was a little bit more inclusive in terms of duration of disease. The French study looked just for 2 years of disease or less, also showed a very high complete response rate and also a reduction in allele burden. This is just a really nice sort of phenotype-genotype correlation here, and alludes a little bit to the talk earlier today. What we see in the top rows 1 through 9, are the patients who achieved a complete molecular response, and looks at their other mutations. And you can see, first of all, just fewer additional mutations that are commonly seen in this group of disorders in the people who achieve a response, so perhaps a less genetically complex disease, and also mutations that get lost. That's depicted in blue in serial samples. And by contrast, the people with less than a complete molecular response have a genetically more complex disease and persistent mutations. So I think this is a really interesting observation. So I think I just speaking to Ruben about, seeing the young patient who is otherwise low risk, typically very well educated, and any discussion about likelihood of transformation is never very reassuring for these patients. And so I often get the question of, I have no indication for cytoreductive therapy, but should I be taking interferon anyway because I think it'll make my disease go away? And the answer is, perhaps in the setting of a clinical trial, we should try that. But this, again, this question comes up a lot. There's really not a lot of data out there. This is, again, a publication by Dr. Silver, essentially a case report of some reduction in bone marrow fibrosis at diagnosis and then after treatment. So just to summarize, interferon highly active in ET and PV. It reliably reduces the clonal burden of disease, very novel compared to our other therapies. It's the treatment of choice. Again, we're sort of in expert opinion realm and not necessarily fully data-driven, but in pregnant patients who require cytoreductive treatment, usually that's a pretty rare, and resistant or intolerant to hydroxyurea, and younger patients, I think, with low-risk disease who are requiring cytoreductive therapy. I think arguably you could vote for using long-acting interferon. So what about some of the open questions? And some of them might be answered in the next session, but really vascular risk reduction has not been established in comparative studies for interferon. It is the topic of a clinical trial that continues to accrue. This is the MPD Research Consortium. It's an international clinical trial randomizing pegylated interferon to hydroxyurea. I think that we don't know optimal dosing and duration of treatment really hasn't been established for interferon, and that's a question that comes up a lot in people who are responding. The role of primary prevention, so again, the asymptomatic young patient who just wants their JAK2 mutation to go away, I think that's a really important question. And we don't really have a lot of data about symptom control in these patients. And my own anecdotal experience is fairly positive, with some patients having other reactions, but we really need some more rigorous data than my anecdotal experience. And that's all I have to say.